So I do love applied anatomy. Okay, let us start with a very, very important photo or picture or slide. I do love this slide because actually, if you understand this slide, it will be very easy for you to understand almost the whole anatomy of the gastrointestinal tract. As you know, the abdominal GIT is divided into three parts: the foregut, midgut, and hindgut. And you know that the foregut started from the lower part of the esophagus, including the stomach and half of the duodenum. Then the midgut started from the lower half of the duodenum, including the whole intestine, up to 2/3 of the transverse colon. Then the hindgut started, including the lateral third of the transverse colon, the sigmoid, the rectum, and up to the upper or middle of the anal canal, middle half of the anal canal. For each gut, it has its own arterial supply. As you know, this is the dorsal aorta, and here we have the celiac trunk or celiac artery, which is give the whole blood supply to the foregut. That means the lower part of the esophagus, stomach, and half of the duodenum. Then we have the superior mesenteric that lie at the level of L1. This is exclusively related to the midgut. And finally, we have the inferior mesenteric that originate at the level of L3, and this is the main blood supply to the hindgut. And by knowing this, you can easily identify all the things related to any structure of the GIT. Like, if you are talking about the, let us say, appendix. So the appendix is, what is the blood supply of the appendix? Appendix is related, is it foregut, midgut, hindgut? It is midgut. So definitely it must take a blood supply from the superior mesenteric artery. Okay. Stomach, is it foregut, midgut? Definitely it is foregut. So total blood supply must come from the celiac trunk through their branches. And the same goes for the whole thing. If I ask a very simple question, what about the duodenum? What is the blood supply of the duodenum? So you will ask yourself, is it foregut, gut, hindgut? Yes? Duodenum? Foregut or midgut?
Midgut.
Foregut
Forget.
and midgut. So it comes from dual origin. One, the upper part is coming from the foregut and the lower part coming from the midgut. So definitely it may take its blood supply from two sources. That means celiac trunk and the superior mesenteric artery. Why? Because it's a mixture of foregut and midgut. The same goes for the transverse colon. Transverse colon is a combination of a midgut and hindgut. So definitely it must take dual blood supply. Branches coming from the superior mesenteric artery and the other come from the inferior mesenteric artery. As you know, definitely it comes from the lateral colic. So by knowing this, we know everything about the blood supply. Not only that, all the foregut or structures of the foregut drains its lymphatic to the celiac trunk, the lower part of the esophagus, the stomach, and the upper part of the duodenum. All the lymphatic drainage must go to the celiac lymph node. Where are the celiac lymph nodes? They are a group of lymph nodes around the origin of the celiac trunk at the level of T12. The same goes for the midgut. All the structures belong to the midgut, whether it is jejunum, ileum, cecum, appendix, ascending colon, and part of the transverse colon must go, it drain its lymphatic to the superior mesenteric lymph nodes around the origin of the superior mesenteric artery at the level of L1. What about the transverse colon? The lymphatic drainage of the transverse colon. It must go to both the superior mesenteric artery, superior mesenteric lymph nodes, and the inferior mesenteric lymph node. Why? Simply because it is a derivative of midgut and hindgut. And by knowing these facts, I think it is very easy to you to recognize the blood supply, the nerve supply. Also, we'll talk about the nerve supply later on. And please keep this graved in your mind, this slide, because it facilitates everything to you. It makes every understanding anatomy is very easy by knowing the origin of the gastrointestinal tract. Okay, so let's just go on. Arterial supply of the gastrointestinal tract, as we mean, you know, we have the first is the celiac trunk. That is the main blood supply to the foregut. What are the structure belong to the foregut? Definitely, it is the lower part of the esophagus, stomach, and upper half of the duodenum. It has, you know, it has 3 branches. Of course, the origin is the lower part of the T12. That means thoracic vertebra number 12. It have the left gastric, the splenic, and the hepatic. This is the main blood supply or arterial blood supply to the foregut. The midgut, it takes from the superior mesenteric artery that originate at the level of L1. It has almost 6 branches that give blood supply to the structures of the midgut. I mean the lower half of the duodenum, ileum, cecum, appendix, ascending colon, 2/3 of the transverse colon. These 6 branches are, you know, it's inferior pancreatico-duodenal, jejunal, ileal, mid-colic, right colic, and what's the other one? Ileocolic. 6 branches. And finally, we have the last branch, anterior branch of the aorta. You know, the abdominal aorta, actually, when it pierces the diaphragm at the level of T12, it's called abdominal aorta. It has many lateral branches, like the gonadal, the suprarenal, the renal, the lumbar, and it has 3 anterior branches. These are the celiac, superior mesenteric, inferior mesenteric. We call it anterior branches, and terminal branches, the 2 common, iliac and the middle sacrum. So these are the 3 anterior branches of the abdominal aorta. So the inferior mesenteric, we have left colic, the sigmoidal, and the superior rectal artery. These are the main blood supply of the abdominal gastrointestinal tract. The venous drainage actually is unique for the gastrointestinal tract. It has a unique venous drainage, mainly come through, I'm sorry, I'm rushing a lot because too many things to be said and the time is so limited. Mainly we have the portal circulation. You know about the portal circulation. Why it is unique? Because simply we don't know what we are eating, what's inside our food or drinks. Too many harmful particles and substances are there, whether it is nasilima or whatever. Yeah? So the blood that comes from the gastrointestinal tract actually cannot go directly to the inferior vena cava, I mean the heart. Why? Because it may contain a lot of toxins, a lot of harmful substances, need to be filtered in a factory. This factory is the, yes?
Liver.
Yeah, the liver. So the blood, the venous blood that's related to the gastrointestinal tract with their accessory gland cannot enter directly to the systemic circulation. It must be filtered first in the liver, and then only then it can enter to the systemic circulation. That means the inferior vena cava through 2 or 3 hepatic veins, because a lot of things happen in the liver later on. What's happened in the liver, and for that reason, I can say that in the abdomen, of course, you know, medicine and anatomy needs a lot of imagination, and in our abdomen we have 2 types of venous circulation. One is specific to the GIT, we call it portal circulation. You know, the portal circulation that convey the venous blood from the whole gastrointestinal tract to the portal vein. This is the portal vein. It's about 4 centimeters in length. It has no valve. It is the union of the splenic vein with the superior mesenteric vein, where behind the neck of the pancreas at the level of L1. I like this level L1, or in surface anatomy we call it transpyloric plane. A lot of important things occur or lie at the level of L1. And now the whole tributaries of the portal vein drain to the portal vein, then the portal vein enter the liver. Inside the sinusoid of the liver, a lot of important procedures, things happen, detoxification, filtration, and then, and only then, the blood that come from the GIT can enter the inferior vena cava safely. This is the first circulation. We have another circulation in the abdomen. I'm talking in the abdomen, that we call the systemic circulation, which is the inferior vena cava, of course, with its tributaries. Okay, the inferior vena cava, tributaries that come from the, you know, the iliac veins, the lumbar veins, the renal, the gonadal, the suprarenal, and we know that there is some anastomosis between these 2 important circulations, the systemic circulation and the portal circulation. I will touch this later on tomorrow, hopefully, about the portal systemic anastomosis. For the autonomic nervous system, we know that the GIT, all the visceral structure are supplied by autonomic nervous system. What is the autonomic nervous system? It is the nerves that act beyond our consciousness. We have no control on it. I return back to the imagination. I do love imagination in anatomy and medicine. You need to be very good imagination to be a good doctor. Autonomic nervous system, actually, which acts as a control system functioning below the level of consciousness, mainly related to the visceral function. We have the sympathetic and parasympathetic. I will touch a little bit about this. I will not enter into full details because it needs 2 or 3 lectures to. The sympathetic, or we call it fight and flight, exactly like that come from T1, that means thoracic vertebra number 1, or spinal cord, up to L2, lumbar 2. This will give us the sympathetic flow to the gastrointestinal tract. You know, this cat is now in an emergency situation. So it is thinking either to fight this dog or run away. Actually, this is the same occur in our body through the sympathetic. When we suffer or experience an emergency, it will trigger the sympathetic nervous system from T1 to L2. Okay, and also we have the parasympathetic, or we call it rest and digest. Exactly what this tiger or lion is doing after having a heavy meal. Now all the things are dominating parasympathetic. The rest and digest. The flow of the parasympathetic usually comes from two components, the cranial and sacral. Mainly the cranial comes from the 3rd, 7th, 9th, and 10th cranial nerves, and the sacral coming from S2, S3, S4. Okay. The cranial, you know, the oculomotor, I'm talking parasympathetic, facial, glossopharyngeal, that means the 9th, and finally the hero of the parasympathetic, I call it the hero because really it is a hero nerve, the vagus, that give us most of the parasympathetic activity to the gastrointestinal tract. The sacral come from S2, S3, S4, through the pelvic splanchnic, and it will go to the whole. So the sympathetic, I will repeat, come from T1 to L2, while the parasympathetic is coming from two components, cranial and sacral. Imagine you are now surgeons, right? Imagine you open an abdomen of any individual and you are facing the stomach. If you press, imagination, if you press or touch the stomach, the patient cannot feel your touch. Or if you put
Hello, Wilson? We cannot hear you.
And okay, it is not somatic innervation. If you touch your hand now, you can feel. If you put any temperature on your hand, on your chest, you can feel it. Why? Because the trigger is different here, because it is supplied by somatic. So you need to differentiate between somatic innervation and autonomic. Autonomic, I will give you a simple summary of the autonomic nervous system of the abdomen. You know, sometimes you need 1 hour to prepare a slide, and sometimes you need months to prepare a slide. And this slide actually prepared, it takes months to be prepared. So these are the foregut, midgut, and hindgut of the GIT. This is the abdominal aorta. This is the 3 branches, celiac branch, celiac superior mesenteric, and inferior mesenteric artery. Please open your mind with this slide because it is so important to understand the nerve supply of the whole abdomen. Of course, we have here the superior hypogastric plexus and inferior hypogastric plexus. We have the purple represent the parasympathetic and the white represent the sympathetic flow or outflow of the abdominal innervation. This represents the brain or brainstem. This is the spinal cord, the cervical, the thoracic, lumbar, and sacral. The thoracic is from 1 to 12, lumbar 1, 2, and the sacral 2, 3, 4. And here what we have, the sympathetic chain. You know what's the sympathetic chain? It is 2 chains around on each side of the vertebral column that carry the sympathetic flow to the abdomen. And also we have the ganglion where the nerves relay or synapse. This is the celiac ganglia, the superior mesenteric ganglia, and the inferior mesenteric ganglia. Now, let's start our journey with the sympathetic flow to the abdomen. You know, we have what we call it the greater subclavian nerve. The greater subclavian nerve comes from T5, T6, 7, 8, 9. Okay, we call it greater subclavian nerve. It relay or synapse in the celiac ganglia. From this ganglia, it will go to the celiac plexus and reach the structure of the foregut within the branches of the celiac trunk, either the left gastric, the splenic, or the hepatic. Okay, so the first we call the greater subclavian, 5, 6, 7, 8, 9. It relay in the celiac ganglia, the structure to the branches or within the branches of the celiac trunk through the celiac plexus, a network of nerve around the celiac artery. The second, we call it the lesser subclavian nerve that comes from T10, T11, and relay in the superior mesenteric ganglia. And from here, the post-ganglionic neurons follow the branches of the superior mesenteric artery to reach the midgut, giving sympathetic. I'm talking about sympathetic because it is still in the white. The other one, a small one, we call it the least subclavian nerve that comes from the T12. It relays also in the superior mesenteric and follow the same to reach to the midgut. Finally, we have the lumbar subclavian nerve that comes from L1, L2 to the inferior mesenteric ganglia, and from the post-ganglionic neurons now enter the inferior mesenteric plexus to reach to the hindgut. Okay, I think it is very important, very clear to understand. If you have any question later on, you can SMS me or send me whatever you want. Okay, because now we have no time. I'm so sorry. This is for the sympathetic. What about the parasympathetic? Actually, as you mentioned, it comes from two components, the cranial nerves and the sacral component. The first mainly comes from the vagus nerve. So as you see here, the vagus come from the T10, of course, HC10, okay, brainstem. It will reach to the celiac plexus, and from here it gives to the parasympathetic innervation to the foregut, and also it transmits the parasympathetic to the midgut up to the 2/3 of the midgut. As I mentioned, the midgut is included up to the 2/3 of transverse colon. Then the sacral component will take over like this. It comes now, what we call it pelvic subclavian nerve. It comes to the inferior hypogastric, to the superior hypogastric plexus, and it can reach up to the hindgut. So this is the, I will send you the whole slides to the committee, maybe today. So you can get return back to it anytime you want. Okay, so this is for the autonomic innervation of the gastrointestinal tract. We have some applied anatomy of the abnormality in the autonomic nervous system. You know, this is a very, very famous condition that affect mainly the ductors. Half of the ductors have this. What is this? Yeah, this is the irritable bowel syndrome. Mainly it is functional condition, usually said to be it is because of the abnormality in the autonomic nervous system. You know, it's a cramp in the abdomen relieved by diarrhea, and it comes whenever you have stress. And being a doctor is a risk factor. So all of us have vulnerable to have this. Some diarrhea also is related to abnormality in the autonomic nervous system. Even some condition in constipation said to be due to abnormality in the deferment in the autonomic nervous system. The peptic ulcer is said to be because of derangement in the autonomic nervous system, mainly due to increase in the parasympathetic, because the parasympathetic responsible for secretion. Whenever you have secretion in your body, there must be a plenty of parasympathetic stimulation. All secretion in the body is triggered by parasympathetic, with the exception of the sweating, because it's triggered by sympathetic. Okay, not only that, but even the treatment of the peptic ulcer is related to because we know that previously, not now, previously, whenever we have peptic ulcer, we do what we call it truncal vagotomy. If you remember, you're still young to remember these things. The surgery for peptic ulcer before was truncal vagotomy. Then we found a lot of complication to the surgery, so we shifted to what you call selective vagotomy, which is better. Then after a while, we noticed that a lot of problem happened to the patient, so we changed to what we call it highly selective vagotomy. We cut part of the vagus responsible for the secretion, and all of these surgeries are now history, just history, abandoned, with the exception unless you have a complication of peptic ulcer like perforation or hemorrhage, you can still do some of these, because there is a revolution in the treatment of peptic ulcer after the discovery of proton pump inhibitor, and so on. The lymphatics of the abdomen, I will run on these. Unfortunately, I notice a lot of deficiency in the knowledge of lymphatic. I do like lymphatic system too much, because I think it's very important for all doctors to understand what is the lymphatic system. It is a system by its own, and the system composed of lymphatic vessels, lymph organs, and lymph, found in all tissue except these. The CNS has no lymphatics: eyeball, internal ear, epidermis, cartilage, and bone. The function of this important system is the collect and transport fluid from the intercellular space, and it will return back to the vein. Protection of antibodies. So this is the main function, defensive mechanism. And return plasma protein to the bloodstream. It's a manufacturer for lymphocyte, filter of microorganisms. So mainly the function is defensive mechanism and transport. Okay. For the abdomen, actually, we have two important collection of lymph nodes. We call it pre-aortic and para-aortic. The pre-aortic is coming from the celiac, superior and inferior mesenteric nodes, and drain all the GIT through the large intestinal trunk. And we have the para-aortic, or we call it lateral or lumbar, that drain the kidneys, suprarenal, the gonads, the uterine tube, the uterus, the lymphatics of the abdomen wall. All these are ended by two lumbar trunk. So in the abdomen, we have the large one intestinal trunk and two lateral lumbar trunk. These two, the intestinal and lumbar, drain to the cisterna chyli. Cisterna chyli is a sac-like structure just below the diaphragm and commence as the thoracic duct in the chest. And the thoracic duct, this is the green one. If you follow the arrow, it will drain eventually to the mainly to the brachiocephalic or cephalic vein and return the lymph to the. So here is it that the whole body drain to the thoracic duct by this white. All this white area drain to the thoracic duct on the left side, and the purple one drained by the right lymphatic duct. So more than 3/4 of the body drained to the tube, thoracic duct. Okay. Some applied anatomy on the, what is Virchow nodes? Anybody can tell what is Virchow nodes? Yes? Nobody. Okay. Virchow nodes, it is one of the earliest signs of the malignancy, especially in the GIT. And mainly coming from the stomach. Okay, here is it. In the mainly the left supraclavicular lymph nodes. If you feel it here in your old age, you ought to put a question mark about the origin of this, because it might be the greatest subject, Professor Virchow, and unfortunately he died. He discovered that he himself has one of these Virchow nodes, and he died by pancreatic cancer. I do like also the history in medicine. Okay, so Virchow nodes is also, you will face it in your miserable occupation, the doctors. Mesenteric lymphadenitis is also, you know, for the, we said to our layman that you have another tonsil in your abdomen. Your baby have another tonsil in your abdomen. And this is quite a little bit true, because emergency, mainly the acute appendicitis, this is due to inflammation of the lymphatics of the abdomen that might be misdiagnosed with a lot of surgical emergency. Okay, I will, because our topics is the upper GIT, so I will touch a little bit about the esophagus, and if the time allow. Okay, esophagus. It's just a tube, about 25 centimeters in length, and starting from C6, a very important landmark of the cricoid cartilage that lie at the level of C6 and join the stomach in the abdomen. Here is it. Passes through the diaphragm at the level of T10. That means thoracic level, thoracic vertebra number 10. We have three main hiatuses or hole or opening in the diaphragm. We have a T12 for the aorta and their neighbors. We have a T10 for the esophagus, and we have a T8 for the cava, inferior vena cava. Okay, I will not enter in these details. So the esophagus passes through T10, and as you know, as you see here, the greater part of this esophagus actually lie within the thorax. We have a very small portion, we call it abdominal esophagus, about 2 centimeters in length, and this is the abdominal esophagus, about 1/2 inch. Okay, this is the diaphragm. Okay, this is the caval opening. This is the esophageal opening, and this is the aortic opening in the diaphragm. Okay, actually has very important, the esophagus has very important, we call it anatomical and physiological constriction, which is clinically important. These, the first is at the level of cricoid cartilage, that means C6. Okay, The second constriction of this is the esophagus. You see, this is the esophagus, the most posterior one. The second constriction is the left bronchus and the arch of the aorta crosses in front of the esophagus. So here's number one, here's number two, and finally when it enters into the stomach. So three important. Why I say important? Because we found that the strictures, if there is any, occur at these three important clinical constriction. Not only that, even the cancer of esophagus used to be in this three important constriction, either at this level or the cricoid or when it enters the. So that is it is said to be, it's clinically very important to understand these constriction. Okay. Actually, there is no anatomical sphincter at the lower end of the esophagus, only physiological. So what do you mean by anatomical sphincter? Anatomical sphincter is thickening of muscle, like what we will see in the stomach, in the pyloric sphincter, thickening of the muscle, real thickening. But here, there is nothing abnormal in the muscle because it is said to be physiological, although it is patent, but it is physiological, not anatomical sphincter. And this actual esophagus is very important to divide it into three parts: upper, middle, lower. Upper part, middle part, lower part. Why I said it is very important? Because all the management of the diseases, condition affecting the esophagus will depend on this, as we will see later on. So the blood supply of the esophagus can be divided into three origins. First, for the upper part, it comes from the inferior thyroid artery that comes from the subclavian, very high. So the subclavian, through its branches, the inferior thyroid artery, give arterial supply to the upper part. The middle comes from the aorta through the esophageal. This is the thoracic aorta through the esophageal branches, completely different from the upper. And the same goes for the lower. It comes from the left gastric, from the abdomen. The left gastric is the first branch of the celiac trunk. And you know the celiac trunk, the left gastric branches ascend with the esophagus to reach and give blood supply to the lower part of the esophagus. Okay. The same goes for the veins. The upper part drain to the inferior thyroid artery, inferior thyroid vein. While the middle, it will go to the azygos. This is the azygos and hemiazygos. And the lower part, it will go to the portal circulation through the left gastric vein, which is a tributary of the portal circulation. And this is a very, very, very important portosystemic anastomosis at the lower part of the esophagus. Okay. And you can see the difference. Not only that, for the nerve supply, of course, it will take from the vagus as parasympathetic and sympathetic from the sympathetic trunk. Another important applied anatomy for the esophagus is the drainage. Upper part, it will drain its lymphatic to the deep cervical lymph nodes, while the middle to the superior and posterior mediastinal lymph nodes. And the lower, it will go to the abdomen through the celiac nodes. And you can see this is very important in the management of any disease, especially when you are dealing with cancer. If there is a cancer tumor in the esophagus, you know it's not enough to remove the tumor from the esophagus, but also you must deal with the lymphatic drainage of that tumor, whether surgically or by another, either radiotherapy or what else. So if your cancer in the esophagus in the upper part, the incision is quite different. You do a transverse in the incision in the neck, and you remove the affected part, and also you must go to the deep cervical lymph node to deal with these. Where is these? Where are these lymph nodes? Internal jugular vein in the neck. If your cancer in the middle part of the esophagus, you need to open through the thoracotomy, and you must go to the superior and posterior mediastinal lymph nodes. These are in the posterior mediastinal. While if your lesion is in the lower part of the esophagus, you ought to open not only the thorax, but also we do sometimes extended thoracotomy through the thorax and the abdomen. Why? Because the celiac node is not in the thorax, it is in the abdomen, and so on. Okay, so dividing the esophagus into three parts and understanding the blood supply, the nerve supply, the lymphatic is of crucial importance to understand the problem. A very common, you know, the GERD, we call it gastroesophageal reflux disease. You know, this is the normal esophagus and the stomach, and this is the GERD. Usually, even if you are in upside down, your stomach content does not go to the lower esophagus, because these, although it is physiological sphincter, but it is patent. I repeat, even in the upside down position of any individual. If it is just like that, this is what we call it the GERD. And the stomach content can produce some symptoms of heartburn in the lower esophagus. Because the mucosa become inflamed, and the lining of the esophagus can change from squamous to columnar epithelium. And by doing such, there is a risk of development of adenocarcinoma at the lower end of esophagus. Okay, so GERD, if there is transformation of the epithelium from squamous to columnar, it might lead to the metaplasia and finally adenocarcinoma of the lower end of the. Because of this, many causes, mainly due to failure of the lower esophageal sphincter or hiatus hernia, and definitely abdominal opacity. A bleeding varicose vein or esophageal vein. You see, this is the liver is a little bit cirrhosed, so the blood cannot enter easily into the liver, so it is shifted to the portosystemic anastomosis and mainly the lower part of the esophagus. At the lower third of the esophagus, as we mentioned, is important portosystemic venous anastomosis, and the left gastric branches, which is portal vein, anastomose with the branches of the azygos, which is systemic. So if the portal here vein become obstructed, like in cirrhosis, portal hypertension develop, result in dilatation and varicosity of the portosystemic anastomosis. We will take this tomorrow, inshallah. Okay. And this varicose veins may rupture, causing severe vomiting of blood, and sometimes it is life-threatening if you are not prepared well to the management of this, because your patient might lose about 1.5 or 2 liters of his or her blood. Okay, and it is an emergency, surgical emergency. For the stomach, I'm so sorry again because I'm rushing for this topics, because the time is so limited. The stomach, this is the stomach, okay? It is the dilatable portion of the alimentary canal, a capacity of about 1.5 liter. Where is it? Of course, it is in the upper part of the abdomen. It is relatively fixed at both ends and very mobile in between. For that reason, it is protected from the blunt trauma to the abdomen. However, because it is a little bit proportionally large, it is vulnerable for gunshot wounds. Because it is mobile, it is very rarely affected by blunt trauma. But because it is big size, it is liable to have a stab injury or a gunshot and so on. As you see, it is just like a J shape. It has 2 opening, cardia, pyloric, 2 curvature, lesser curvature, greater curvature, and 2 surfaces, anterior and posterior. It can be divided into 4 parts. Some books divide it into 3, but here we divide it into 4. The fundus, this is the fundus, which is dome shape, which is filled by gas. Then we have the body, which starts from the cardiac orifice to the incisura angularis. This is the margin. We call it incisura angularis. This is the body. And we have the antrum from the incisura angularis to the beginning of the pyloric or pylorus. And finally, we have the pylorus portion, which is a tubular part of the stomach. And it has the pyloric sphincter, which is a real sphincter, anatomical sphincter, not like here. Here we have a very thick muscle that is represents the anatomical sphincter. Okay, then we have the portal canal. The peritoneal folds, whenever you hear something called omentum, that is something peritoneal folds related to the stomach. Omentum means related to the stomach. So we have the lesser omentum, here is it, that connect the lesser curvature of the stomach to the porta hepatis of the liver, which is twofold of peritoneum that connect the lesser curvature to the porta hepatis. And we have the greater omentum, that's two folds of peritoneum that connect the greater curvature of the stomach to the transverse colon. This is transverse colon. And here we call it, you know, the surgeon call it the policeman of the abdomen. Why? Simply because it acts as a defensive mechanism. Whenever you have infection, this greater omentum try to go to the side, like in the appendicitis, you will find, of course, you open a lot of laparotomies and you might find that the greater omentum act as a policeman, try to localize and minimize the spread of infection. So, or if you open the abdomen for a perforated DU, you might see the part of the omentum stuck to the hole of the perforation, owing to decrease the spread as much as it could. Okay, for that reason we call it the policeman of the abdomen. We have another one between the stomach and the spleen. We call it the gastrosplenic omentum, extend from the upper part of the greater to the spleen. These are, and you know, the stomach is almost completely surrounded by peritoneum, so it is an intraperitoneal organ. If there is, I don't know, I don't think, but you will find a lot of peritoneum in the slides that I will send you, okay? Because actually there is no structure in the abdomen is really intraperitoneal. This is a misnomer, okay? Maybe only the ovary is real in the intraperitoneum or intraperitoneal. The other are called intraperitoneal, but in actually they are not. Okay. The stomach, where is the stomach? Here is the stomach. I do love this slide because it can explain everything in the abdomen. As you see, anteriorly for the stomach, we have the anterior abdominal wall, the left costal margin, the left pleura and lung, also the diaphragm, and the left lobe of the liver, because the liver is so huge, is not only in the right side, but also it can reach up to the liver. Posteriorly, we have the lesser sac, which is very nice, and the diaphragm also. As you see here, transplenic artery, pancreas, of course, and the transverse colon and mesocolon. Okay, blood supply is so rich. It takes from please you can stop me when the time is over. Okay, anytime you can stop me when the time is over. Okay, so blood supply usually it takes from 5 sources. The left gastric, this is the left gastric artery, and as you see, it runs along the upper part of the lesser curvature. We have the right gastric, come from the hepatic. This is the right gastric. We have the short gastric arteries, about 5 to 7, that come from the splenic artery. It is very important. You need to know that it runs in the gastrosplenic ligament, and we have the left gastroepiploic, also come from the splenic, and finally we have the right gastroepiploic artery. Very rich anastomosis between these branches, so I can sometimes sacrifice 1 or 2 or even 3 of these, and still the stomach can survive. Okay, the veins, all these goes to the portal circulation. So as you see, left gastric and right gastric go to the direct portal circulation. Short gastric, left gastric go to the splenic, and then it will go. And finally, we have the gastroepiploic. The idea that all the foregut will go, not only the foregut, all the GIT will drain its venous to the portal circulation. Okay, the lymphatic drainage is also important. It always follow the arteries, so it will go, because the stomach is foregut, so it must go to the finally, the final destination is to the celiac lymph nodes around the origin. Why to the celiac? Because it is a derivative of the foregut. Nerve supply, sympathetic through the celiac plexus and parasympathetic to the right and left vagus nerve. Actually, the left vagus become the anterior vagal trunk. The vagal nerve, when it pierces the abdomen, it will change its name from the vagus nerve to vagal trunk. And because the rotation of the abdomen in the embryo, so the left vagus become anterior vagal trunk. Here is it, the anterior vagal trunk, the left vagus, and the posterior vagus become the right vagus trunk. Posterior become the right become the posterior vagal trunk. Okay. Still, we have time to continue.
I think we got left 3 minutes at the time.
3 minutes. Okay, okay. I will try to finish. Duodenum. Okay, the duodenum, as you see, this is the duodenum, C-shaped, about 25 centimeter. It is so important because it receives the opening of the bile. This is the bile and the pancreatic duct, curved around the head of the pancreas, and it is retroperitoneal structure with the exception of the first inch, not the first part, only the first inch of the first part. It is intraperitoneal, and as you see, the mucous membrane here is smooth, The other we call too many folds. We call it plissé or pliqué circularis, as you see here. Okay, can be divided into 4 parts. This is the first part, second part, third part, and fourth part. First part, here is it, smooth, begins at the pylorus and run upward and backward on the transpyloric plane. Here is very important relation to the gastroduodenal artery, which is very important because you know the peptic ulcer, hemorrhage in the peptic ulcer bleeding usually come from this nagging artery. We call it the gastroduodenal artery. Okay. The second part is the most important part because the bile duct open with the union of the main pancreatic duct of forcing and the major duodenal papillae. Okay. And which is guarded by the sphincter of Oddi. Sometimes we have another duct, we call it accessory duct of Santorini, that open a little bit higher in the minor duodenal papillae. You know, through this papillae, we can do the ERCP, endoscopic retrograde pancreatic cholangiogram. We introduce through the mouth, through the esophagus, stomach, and then when we reach here, we enter, and it's up to us. Either we go to the bile or we go to the pancreas ducts, and we can do whatever we want. The third part, here is the third part. The fourth part, run upward, this is the fourth part, to the duodenal flexure. And here, an important ligament. We call it ligaments of Treitz. Why it is important? Because here is the demarcation between the upper GIT and the lower GIT, is the ligament of Treitz. Actually, this is only in surgery. In anatomy, we don't have such demarcation between upper and lower. But in surgery, we call it upper GIT bleeding. That means all the structure proximal to the ligament of Treitz called upper GIT, and the distal to the ligament of, this is the ligament of Treitz that connect the duodenal fracture to the diaphragm. Okay, I will close or finish with this duodenal ulcer. Why usually the ulcer is more prominent and more common in the first part of the duodenum? The theory mentioned that as the stomach empties its content into the duodenum, the acid chyme is squirted, rushing or pushing its content into the anterolateral wall of the first part of the duodenum. This is thought to be an important factor in protection of duodenal ulcer at this site. Okay. Important relation to the duodenum. Usually you need to notice to the gallbladder, transverse colon, and right kidney. Okay. Cases have been reported in which large gallstone ulcerated through the gallbladder wall into the duodenum. Okay. Operation on the colon and right kidney have resulted in damage to the duodenum. I think I have to stop here. Unfortunately, I do love giving you more details, but time should be respected. Thank you very much for your watching. Hope I do something of benefit to you. Any question, you can simply SMS me or send me whatever. I will be more than happy to answer your question. Thank you very much. Thank you. Assalamu alaikum wa rahmatullahi.